This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey there, welcome back to season 2 of It's Not In Your Head podcast with myself, Justine Feidelson, and Dr. Dan Bates. Hello again, Dan.
Hey, Jaz. How are you today?
Good. Today, we're going to cover a topic that was born out of a great conversation Dan and I had the other week, basically chatting about the complexity.
Let's be honest. This is a mental health, this is to save Dan's mental health. This is a mental health podcast for Dan. Because
this is true, because Dan had a bit of a meltdown.
I needed to come up with a solution after I had a meltdown.
So you basically visited a conference where the solution to the difficulties complex patients have working with doctors was essentially to report doctors, to the medical board, which
it was awesome. I really loved that solution.
Which you can see why that was triggering.
Mm-hmm. And so I thought, okay, I'm not sure that. Oh gosh. Anyway,
there's got to be a better way.
So I was at a conference. I'd gone to this conference. It was mainly patient facing, but a lot of clinicians in the rooms, and super difficult. Like from a medical perspective and physiological perspective, difficult disease processes experienced by patients, and so super complex. And one of the continued themes was lack of access to doctors,
right,
and difficulty getting into doctors. And then for some reason, I don't know what they were thinking, but anyway, they promoted when you had conflict with doctors that you should report them to the medical board, and then put up a bunch of regulatory bodies on the
to do so.
Oh my God! on the PowerPoint of who you could contact to report your doctor to, and I was thinking, there's a little bit of a dichotomy here that if you want the doctors to see
to help you
and help reporting them to the medical board.
So Dan's furiously texting me, and then had a bit of a meltdown for 2 weeks after, because although this is kind of galvanizing for patients, and on one hand I understand that you're trying to empower them, but really it's achieving the opposite, because now you've just widened the gap between providers even wanting to see complex patients and patients having any tools to better communicate their needs and actually get to the bottom of the problem they're trying to solve.
Let's put a little bit more context around it. Negligence is negligence, okay? So that, no problems.
Fair.
And there were some stories that were told within that conference that, they should be reported to the medical board. No doubts, okay?
Right.
But I think that stepping outside the realms of negligence, and it becomes counterproductive. And I think that basically the solution of report the doctor or the clinician to the medical board versus, well, actually, let's sit down, have a discussion about why these conflicts take place.
Right.
Why is it that doctors respond in the way they do? And what we're talking about is that doctors respond in a way where they tell the patient it's in their head or it's whatever.
You feel blamed. Right. It's patient fault.
They blame the patient. So why does that take place? And what other options do we have that you can own yourself? And what other options can we give to the doctor so that they don't go through that process of, okay, I don't know, you must be crazy,
right,
et cetera, et cetera. And so that's what this podcast is about. And so what we want to do is maybe just put together a structure for complex patients to be able to direct their own care, and then a set of tips along the way about, well, if you're a doc or you're a clinician in this and you're faced with with a complex
these types of patients,
how do you manage that? And so here we go.
Yeah. And we've touched on different themes of this, better understanding where a provider's coming from and where a patient's coming from. And so some of this will ring a little bit familiar, but we'll dive into each of these different subsets so that you as a patient can really follow a clear structure and make the most out of the time you have with your doctor and working within the limitations of the system that we're all operating in. So shall I run through those, Dan? Just kind of
So kick it off. 1 to 8.
1 to 8. All right. So the first one is, like Dan just touched on, You have to own your own care. That involves a bit of self-assessment and education, which is a lot of what this podcast is about as well, so that patients have language and terminology and different tools and things that they can use to better break apart a very confusing, overwhelming picture and better understand it themselves, because you can't communicate something that you don't understand well to begin with.
Yeah, and for that, you can listen to the podcast, but also on the website, there is a bunch of outcome measures that you can download and do yourself that help start building, some self-assessment tools. So you understand, how depressed actually are you, and, how sensitized are you, and how, et cetera, et cetera, et cetera.
This is the assess your pain episode. So go back and check that one out and look at all the things on the website related to that. Perfect. Second one is create your own problem list, right? So complex patients have a lot of different problems. The first step in seeing all of that is writing that all down, having it in front of you. The next step to that is being able to actually prioritize those problems, because as complex as we are, you can't get every problem solved in one appointment or even a couple appointments. So it's really important to be able to prioritize those things and then, break those apart relative to what doctor you're seeing, because you're going to end up in multiple specialties usually the more complex you get. Part of that is then matching that problem to that doctor that you happen to be seeing. So some things that are under a different umbrella, like headache related stuff, maybe might not be as much under Dan's specialty as, someone else's. Next point, write down your history, right? Have that clear in front of you, including symptoms, and also have your results available. So whether those are things like MRIs, some of these different assessments, anything you think can help your doctor solve the problem that you're trying to get help with. Next point to that is doctors are inherently problem solvers, right? That's what they're there to do. So you have to be able to give them the problem and then help facilitate them working through that problem. And every doctor will have their own way of approaching this and, pulling information out of you. But at least if you have a way to communicate that as well, it makes it a lot easier. Next point to that is don't leave stuff out, right? Sometimes as the patient, we like to decide, oh, that's not important. This is important. Give it all to them and let the doctor decide that part of what is important or not, because if you don't, it just unfortunately creates a lack of trust and breaks down the therapeutic relationship from the beginning, which creates a difficult situation for you and a very difficult situation for the doctor. And the last point is that it is okay for the doctor to say they don't know, like we've talked about in previous episodes. And as a patient, although that is sometimes frustrating to hear, you have to be okay with that, because no one person can know everything. And this is part of where you have certain points at which, all right, you're going to get referred out to something that is not so much the zone of genius or the comfort level that your doctor, is most comfortable working in. So that is our 1 through 8 list. And we'll kind of dive into every one of those now going forward.
Yeah. So
own your own care.
Own your own care. I think a lot of we have talked about this so often over the last 18 months, nearly 2 years, in that chronic pain patients, whether you become so complex, and because of the limitations of time within any medical consult, it's very hard to sort of pull everything together at any one time. And so the only person that has the ability to have a complete understanding of your problem set is you. And so you need to be able to go through understanding what your problem set is and educating yourself around as much as you possibly can, be able to do a set of self-assessments that then bring you in line with where doctors will be thinking. And so I suppose the easiest way within that is sort of, the mental health realm, where there's plenty of outcome measures out there, that
questionnaires you can use,
and questionnaires that lots of doctors use, that you can fill out for yourself, and you can go, you know what, I'm moderately depressed at the moment. And it just gives you that sense of where you're at and what you need to do with. The other thing is that you might go that, you might fill out an outcome measure like a DAS-21, which is the Depression, Anxiety, Stress score, and you might find you're extremely severe. And for you, that then allows you to prioritize. I didn't realize. I thought it was just normal to be like this. And then that allows you to then prioritize, okay, I'm going to get this sorted out. I'm going to get involved with psychologists, psych, blah, blah, blah.
Right. Well, and it may be quote unquote normal, but if it's into the realm of it's really negatively affecting your care, your ability to deal with what you are, then it becomes a real problem. And part of that too is putting your experience into language that the doctor understands, because the doctor is familiar with these types of questionnaires. If you just go in and you're like, oh, I'm really depressed, I'm really anxious, it's not that that's not helpful, but it's even more helpful if you can communicate it in a way where the doctor looks at it and they have a way to better understand within, their own structures how much you're struggling.
Now, prioritizing outside of doing it in that sort of way, and outside of prioritizing relative to what really impacts on the things you want to be able to do, prioritization's hard. Okay. And I think that there's certain disease processes, there's certain symptoms that drive other symptoms. There's, within the world of hypermobile EDS, you'll have not only, the protein metabolism disorder that's driving things, but then you've got mast cell activation that will be driving things, and you've got POTS symptoms that will be driving things, and then you've got GI, autoimmune disorders, and then you've got GI. And so it becomes difficult. What you want to do in that setting is not necessarily manage the worst symptom, but manage the main physiological driver. That is getting really complex, and that's not necessarily for you to work out, but it's for you to then get people to help you work that stuff out.
Yeah. And that's where if you can have all the information to give, then the doctor can use it within the structure that they use and how they look at that disease process or that pathology.
Yeah. And look, and hopefully, with coming podcasts, you'll be able to sort of see some of like how you might prioritize your own problem list, which has been part of the reason why we haven't done much lately, because we're doing
it's complicated.
Some big stuff. So anyway, the next thing is like point number 4, match your problem to your doctor. Okay. So the simplest idea there is if you've got an autoimmune disorder, don't see an orthopedic surgeon. They don't know anything about it. And even more, they don't care. So, and so if you can match the problem to the doc, and that becomes really, really powerful in that, okay, now you're starting to get good control and good advice because you're not seeing the wrong people for the wrong problem.
Everyone's working on what they're best at working on, which is important.
Very few people are generalists. So because there's so much stuff just within specific areas of medicine that everyone gets specialized, which then creates the problem of siloing. So, you get cardiologists that deal with the cardiology beat, you get the neurologists that deal with the neurology beat. And even though the same problem's driving the same symptoms, they deal with them completely differently. And that's difficult.
Yeah.
Thus, you come back to the complexity of chronic problems and chronic pain. And so you've got to be able to deal with it yourself.
Well, and this is why you have to be in charge of your care and the point man to be able to sort of direct, because, Dan has an understanding of hypermobile EDS and POTS, but a lot of doctors, even Dan at times, would refer to a cardiologist maybe for some of those more specific treatments that, he knows of them and he knows enough to help direct care, but it's not his specialty. So how can you do that in a way that does the disease process justice, but isn't incredibly overwhelming, for the patient, where you feel like you rack up a million different diagnoses, but actually they're all related, or one thing is driving it. But yes, we all have different things that we're best at working on, which is fair and reasonable.
All right. So you've quickly worked through, quickly in the background over many weeks and months, you've put together, like you've done your own assessment, you're building your education base, you've created your problem list, you've then prioritized, and you've found somebody that is okay, I reckon this person is the right person to then deal with this component of my problem list. And so the question then is, how do you then communicate effectively with them to be able to get your problem solved? And so what I wanted to do here is I wanted to explain what is it that we as doctors are doing when we are starting to ask a bunch of
what
questions.
Are they looking for?
Like, what am I doing as I start asking stuff? And it took me a while to work out what I actually was doing. So number one, what you're doing is, I have a sitter as like the rules to practice medicine by. We'll do a podcast.
It's its own Dan's rules episode. But briefly,
rule number 1 is don't kill the patient, and rule number 2 is don't harm the patient. So what am I doing when I'm first talking to somebody? And every doctor is doing the same thing. We are trying to work out, do you have something that's going to kill you or is going to harm you for the long term? And so you may get a set of what you consider to be irrelevant questions as the doctor's ticking those things off. Now, we might tick those things off as we watch you get out of the chair. We might tick those things off as we watch you walk down the corridor, or, you know, what you say or how you answer the question, how are you? And I'm doing all those sort of things as I'm speaking to people.
Right.
But that is the first thing we are all doing. We are all doing, does this patient have something that's going to kill him?
Yeah.
Yes, no.
Yeah.
Great. Let's move on to what's next. The next thing that we'll go on to do is we'll go on to ask a history. And so when you start taking a history, the thing about the history is that you will ask a question. And so what it's not is, it's not a question and answer session. Okay. So I ask a question, I get an answer. That question answers that answer. That's not what's actually taking place. What's actually taking place is I'm generating a hypothesis that I think this patient has this problem.
Right.
I'm going to ask this question. The answer to this, if the patient does have this problem, the answer will be this. If they don't have this problem, the answer will be this. If it's unclear, it'll be something in between. And so ask a question, I get my answer, and they'll go, okay, the answer is yes, I continue down that pathway. If the answer is no, I pivot.
Yeah. So it's a live dynamic process. It's not predetermined.
Yeah.
Thus,
So for instance, if I say to somebody, I'm seeing somebody with back pain, that I think that this is coming from the facet joints, which is the little joints at the back of your back, which when someone says, I've got arthritis in my back, that's what they mean. I've got arthritis in these joints. And I'm going to ask a question that is going to be, what's your pain like in the morning? Okay. Right. So I'm going to be looking for, it's worse, it's better, there's no difference. Okay. So if it is facet joint arthritis, they're going to say to me, it's worse in the morning. It lasts for about 10 to 15 minutes. I get better after I have a shower. Perfect. Okay. I continue down this is arthritis pathway.
Right.
Someone says to me, yeah, it's worse in the morning. All right. How long does it last for? About 2 hours. Okay. I've pivoted. So once you're getting over this magic 60-minute number, you're starting to think about inflammatory disorders. So now I'm starting to think about psoriatic arthritis. I'm starting to think about spondyloarthropathies. I'm starting to think blah, blah, blah. And so all of a sudden, then I'm going to pivot and start going down the track of asking another set of questions. And so although you ask a single question, you answer multiple, you're answering multiple things. Another great example is if I ask, do you have any heart disease or have you had any heart attacks before? And someone says yes, well, then I'm going down the track of, okay, when did that take place? Because if I'm thinking about doing a procedure on you and you've had a heart attack in the last 6 months, or you've had a stent in the last 6 months, and I need to do a procedure that I have to stop your blood thinners on, I could
good to know now.
That that is a high risk.
High risk.
I can kill you doing that. Okay.
Yeah. Well,
and so if you say to me, no, I've never had a heart attack, or I'm always said, well, we haven't had a heart attack, which means they haven't had a stent, they haven't had this, they haven't had this, they haven't had this. Like I've ticked off a whole bunch of safety questions by just asking a single question. And so I can continue down my management strategy. So doctors we are asking questions that appear irrelevant, but each one of those questions actually answers multiple things in the background, and they're answering a hypothesis. They're not necessarily answering a question.
Yeah. So sometimes that's the mismatch, where it's in line with the doctor's line of thinking, not what you go in there thinking that they need to ask, or the information that you want to give. And it's kind of this disconnect of, why is he asking me this? This isn't important, but it is important given the background and the context that Dan is using to test his hypothesis and problem solve. Exactly.
Yeah. So the thing that becomes interesting there is, and this is what becomes difficult when you get into complex patients, is that when I'm doing my history, I'm going through in a sequence. Okay. So this question answers this, that answers this hypothesis. I'm now going to this question. I'm now going to that question. So I'm working through in sequence.
Right.
And I have some strategies that if I have a patient that's a good historian that sits down and goes, okay, this is what's going on, and they just like bang it out. I do everything in a picture on anyone who's seen me will know I've got my diagrams and I draw all over the diagram. And so someone might tell me about how it started, and then they'll tell me what it feels like. And then they might jump to what makes it worse. And then they'll like jump to what makes it like what they've treated it with. And then they'll jump up to what they've like, they can't
worked,
sleep.
What's not worked.
Blah, blah,
Yeah.
blah. So
sequence is not matching now.
the sequence doesn't match, but for me, I've got a strategy to deal with the non-matching sequence. Okay. Yeah. But I literally am drawing all over a page to do that so that I can let the strategies going on in my brain to actually match everything up.
Yeah.
Okay. Now, you know what? A lot of my friends, they don't have those strategies. They don't have a strategy to deal with the random patient. And if you've got brain fog, which good chunk of my patients do, like it is really hard to actually spit out anything in any sort of sequence. Yeah. And so that becomes frustrating. And I think that if you flip that into, and you think about it from your side, and people start, and someone's telling you something, and the story you're trying to figure out something for yourself. You think about what you do for a daily job, or even if it's just, sorting out the kitchen or doing X, Y, and Z, and it's all random.
Yeah,
it generates
creates
this
confusion.
Sense. It creates confusion.
And overwhelm.
It generates this sense of what's called cognitive dissonance, because you can't match, and you get this frustration.
Right.
And I forgot this actually. I don't get this feeling very much anymore, which is good.
Yeah. We talked about this more when we started.
I like 2 or 3 years ago, I used to sit there and I'd feel myself getting increasingly frustrated. When I recognized that I was frustrated, I was going to go, the patient is sensitized.
Yeah. And this is where
this doesn't make any sense.
Yeah.
This is all over the shop. This doesn't make sense. I feel internally frustrated. What the hell's going on? The patient's sensitized. And once I was able to recognize that emotional response to the patient's history,
that's the trigger.
That was the trigger for me to go, okay, let's manage their sensitization. Now, I don't get that anymore because I've got a better structure around.
Well, and because now we joke about now we can see the matrix. Right now we have sensitization defined with all these buckets, and that was part of where there is a real value to being able to have a way to work through this and see it, because then you can avoid that frustration and that dead end where now I can't help the patient and I can't help myself and I feel incompetent and nobody likes that feeling. Yeah.
That piece.
Especially doctors.
What's wrong with me? I can't understand what's going on. So anyway, it's fascinating that I don't feel that way anymore. So
no, it's very different.
So if that's what the doctor's doing, and so what you need to be able to do is you need to help facilitate that for the doctor. Okay, so there's a number of things that you can do to help facilitate that. And firstly, write down your history and bring in your results so that you know the answers to the question. Now, what happens for a lot of people, and I think that they come in and they go, here's my history.
Yeah.
And they give me a 2-page document or 3-page document or 40-page
a binder full of stuff.
Patients want you to read and then magically give them like an answer.
The answer. Right.
But what I need to do is I need to be able to ask, I need to go through my hypothesis generation and ticking my boxes on my way through to be able to then give the answer. And so where the 2-page document or the 40-page document is really important, what it needs to be important for is that if we ask a question and you're not 100% sure of the answer, just flick through your notes.
Yeah.
And I had someone do this actually, it was someone's partner did this really well the other day, where I said, have you had a MRI or whatever it was? And they went, yeah, I think we had one last year. Let me pull it out. And so she went through the folder, pulls out the folder, boom, awesome.
Yeah.
They had no idea what was on it. But it doesn't matter. Like, it was there for me to be able to then look up. I can look at the films. All good.
Yeah. Okay. It's not to give the doctor all that information. It's to be able to reference the important information when they ask for it and have it handy. Yeah. Which is really prioritizing.
Perfect. And like, because you're facilitating the doctor's hypothesis generation and answering, but just giving us a list of...
Without overwhelming them.
Yeah.
That's it. Yeah.
So, and unfortunately, we are humans. We do get overwhelmed. And because, like, let's be honest, our communication skills are not awesome, then for everybody, that comes out in negative ways. And we'll talk a little bit further about how we manage that further down the list.
Yeah.
One of the other things to understand here is also you get this mismatch of importance. Okay. And I think I don't know if we've talked about this before, but a lot of the time.
Yeah. The relevance piece.
The relevance piece. So what happens for doctors is we are looking for what is causing this problem, where what the patient wants to tell us is how much this problem is stuffing up their lives.
How bad it is.
Yeah. How bad it is. And unfortunately, how bad it is gives a context of like where and how well the patient is coping.
Right.
But it doesn't tell us what is actually going on.
It's not helping the doctor actually solve the problem. Yeah.
And unfortunately, what happens then is that the patient feels like they're not being heard.
Right.
And so this is where you get complaints about doctor doesn't listen to me. And the thing is that we are listening.
Doctor doesn't care. Right.
Doctor doesn't care. And it's not, doctor doesn't, we do care. It's just that piece of information doesn't help me answer or find out what the problem is to be able to fix how bad it is.
Well, and if you had 2 hours to talk to the patient, that wouldn't be as big of a deal. But when you have 45 minutes or 20 minutes, that's where it's tough, because Dan's trying to basically set that aside, acknowledge it, but set it aside and keep going down his line of questioning. And that's where sometimes, you lose patience.
Yeah. And look, the other way is that you don't do that. You go and you do 1.5-hour consults. And, but the thing that happens then is that, you get booked out 18 months ahead.
Right.
And like you've decreased that, like there's a decrease in access. Like it's an interesting,
it's a balance. It's an awkward
interesting balance between the two.
Yeah.
However, what is important here is that it's this point in the history taking process that is super important. And sometimes I get it right and sometimes I get it wrong. But how you get it right is you need to acknowledge what's going on for the patient.
Yeah.
And
help
then
the patient feel seen, heard, understood.
Heard, and then move on. And so the way I do that is in essentially a 4-step process. So firstly, I'll say that must or that should. So this is advice for the doctor or the clinician. That sounds. And then you need then pick an appropriate descriptive term. That sounds terrible. That sounds frustrating. That sounds super annoying. That really sounds like really painful. Like, pick what is the right descriptor. If you need it, you can have an enforcer. So you can have that sounds really frustrating. That sounds very bad. Pick something, which then allows the patient to go, I've been heard. He I've been heard. He understands.
He knows how serious it is, how severe it is, right?
The question there, then, because we are running within limited timeframes, I'll then move to say, are you happy if we continue so I can ask some questions and try and sort that out?
Yeah.
And so that piece where you ask permission to continue and the patient says, yeah, no problems, let's keep going, keeps the consult moving. And I think that where some of the frustration comes about is that when we get this situation with patients where they've identified how distressed they are, we're in such a rush because we're already behind. Like
Right.
I was running 2 hours behind the other day. That's like, oh my God, that is terrible. But we're running behind because we're feeling we're under pressure. We don't respond appropriately.
Yeah. And then the patient feels shut
Then
down.
the patient feels shut down, and then we'll just get into this spiral out of
Yeah.
control.
Right. Spiral's the perfect term. Right.
Yeah.
Yeah.
So once again, if you're the doctor, that must be frustrating.
Yeah.
And then, are you happy if we continue?
And I like that too, because there's a, not only is it strategic empathy, but there's an empathetic consent piece in there where it's like, are you happy if we continue? Right. It's not being shoved down their throat or that shutdown feeling. And you are able to ask permission. And then even that helps somebody feel heard and understood and appreciated in a sense. So small things like that add up.
And it's a very powerful communication technique.
And it builds trust.
Yeah. And there's a bunch of others that, we might tap on at another point in time where you just comment on the behavior rather than attribute meaning to a behavior. And so that in itself just allows the patient to explain themselves rather than going down the track of attributing something that the patient does to a specific underlying feeling, which may not be actually real.
Yeah. I mean, and this is hard too as a doctor when we're all humans and have different capacity, right, for this at different times and have our own issues and challenges going on. But if you can, as best as you can, execute that, it's really helpful, even if you don't do it perfectly all the time, right?
Yeah. And to be honest, I apologize to everyone that I don't do it perfectly for because sometimes I get it wrong. Anyway. Okay. All right. So other ways to help facilitate things. So with the doctor, a lot of the time doctors will do pre-screening. Okay. So they'll ask you to fill out a set of forms beforehand that answers a set of questions for them. So for me, on a personal basis, I use essential sensitization inventory. I use DAS-21. So that gives me levels of depression, anxiety, and stress. Okay. Now, the reason why I do that is because with a central sensitization inventory, it's split into subclinical, mild, moderate, severe, and extreme.
Right.
And it basically tells me using a number how much amplification is in the system. And let's say that I have a patient that comes in and they have subclinical, so it's like the number's really low. Fantastic. This is going to be a body part issue. It's going to be focal. I can just go straight down the diagnostic pathway. I'll find out what it is. We'll block, treat.
Block, burn.
Block and burn. We're out. Well, perfect.
And it helps you do that better in the constraints of the appointment because now you've gotten some of this answered without having to go through it verbally. They walk through the door. The time you have, you already know.
Yeah. I'm already moving down that track and I'm going to leave out a lot of the sensitization management stuff because I've already seen what the number is.
Yeah.
The flip side is somebody comes in and they've got a central sensitization inventory score that is super high. Extreme.
Yeah.
Okay. Once you're getting into that, then I'm automatically changing my algorithm. Like I'm going to try and calm down that sensitization before I'm going to go down a diagnostic algorithm.
It's helping Dan prioritize.
Yeah. So I'm prioritizing quickly and that's happening quickly. And so that's why it becomes important. The other things like the DAS-21 for me is really useful. And that it's hard to generate enough relationship with the patient early to be able to dive in and go, actually, like how depressed are you? Like,
let's talk about the deepest, darkest, most painful things in your life.
Let's talk about that stuff. Where if they give you a number, how I will do it is that someone gives me a number. They're in, once again, let's say they're in the extreme range. I can just look at the number and go, hey, you look like you're really struggling. And people, every time this happens, they drop their shoulders and they go, yeah, I am struggling. Okay, great. Let's sort that out. I'm going to get you to see psychologists. We'll
friendly
get that
neighborhood
stuff
psychologists.
Okay. The other thing that's within some of these questionnaires, and particularly something like the central sensitization inventory, central sensitization inventory has got a question in it that is, did you experience childhood trauma?
Yeah.
And like within that, the scale, it's an odd question because it's like rarely what is it? Never, rarely,
Yeah.
sometimes, often, always. Okay.
Yeah.
I like that question because it gives patients the opportunity to say, I got some crap stuff that's happening in the background
Right.
that I am never going to get to within a consult.
Yeah.
I'm trying to work out what's going on.
Right.
To be able to generate that level of relationship for somebody to say, hey, this is my experience as a child.
Yeah.
Like, I'm so far off that. But
it's hard for the doctor and it's hard for the patient.
And it's hard for the patient.
In that setting.
Like, you don't want to
it
talk
can be
about
uncomfortable.
That.
Right.
You don't want to talk about
But you want to acknowledge it and know that it's a piece of your history.
And it's a great, like, I find that question super useful in that people can just go, yeah, this is my background. I'll go, okay, great. I get this. This is going to be potentially other physiological stuff going on that I need to manage differently. And so, and you've helped the doctor solve your problem, but all you did is tick a box.
Yeah.
And you might not understand. And I think the point of explaining all this sort of stuff is that, we're doing lots of things as we're asking questions and as we're getting you to fill out forms. So fill out your forms.
Yeah. And I love too that you said,
please.
Yeah, that you said other physiological changes, because even those types of things, it's not in your head. It doesn't mean that's not at all what Dan is getting at or insinuating. And that's where when patients feel like they can't answer those types of things, or they're scared to talk about or check off those pieces of their history, it's because they're scared the doctor is going to go, go do hypnosis or go see a therapist. And that's the main reason for your pain, rather than an amplifying factor or stress piece or these other things that then, there are changes in your body that take place over time. And when you as a patient are scared to, or you do literally leave out information, it off the bat is creating distrust, unfortunately, and doesn't allow Dan to solve the problem that he's trying to get at. And it breaks down the therapeutic relationship from the start, and is unfortunate.
So the next piece with helping us work through the hypothesis generation and answering is don't leave stuff out. Okay. Yeah. So it's okay if you tell us stuff and
you forget.
It's not relevant. That's okay. Like I literally I'll
Dance does it every day.
I'll go, doesn't answer my question. Let's move on. Let's move on. Doesn't help. But if there is stuff that is relevant, don't leave it out. Like it
and that's what's hard. Like, we as the patient,
it's hard sometimes.
We're the experts of our own body, and we know ourselves best, and that's true. But let the doctor decide what is important and what's not. Don't, as the patient, go, oh no, that's not important. Oh no, my depression is not important. Oh no, my pre-existing history as a child is not important. Like, give them everything that they ask for and need to work with, and let them sift through and sort through that, as opposed to you. Because what that leads to is actually the type of label you most don't want as a patient, which is problem patient, red flag patient. What's that? What do you?
Looking.
Label's not the one is right word.
Yeah. So I think one of the reasons why people don't tell you stuff, because there's fear.
They're scared to be labeled.
There's a fear of these labels, and I've had some patients recently that are like, don't put that in my medical records. And I'm like,
put that in my chart.
Don't put that in. I'm like, yeah, but legally I can't see you and then not put stuff into a medical records, because we have to keep things in a certain structure that has a certain has a certain level of security, certain level of privacy, meets a bunch of guidelines. And as soon as we take that out of that setting, and we just keep it in a folder on the computer,
just a side folder,
you can't do that.
No, then you can't make sense of the picture, and Dan won't remember either.
Yeah, and that is the other thing. I won't remember. Before I see people, I review what I did last time.
You need an at-glance lay of the land, not, this is here, that's there, that's electronic, that's on the paper sticky. Yeah. Doesn't work.
So that interaction doesn't work, and it pretty much, unfortunately, probably ends the therapeutic relationship, because you just can't legally do medicine without recording it, which
Yeah,
is
and this is the piece
difficult.
too, where you can see how important trust is, and having the type of relationship with your doctor where you're not scared to give them information or what they ask for, because there's nothing wrong with being depressed. That makes you normal, unfortunately, in most of these settings, right? And I have also even had patients where sometimes it's a fear of access to medications that causes them to hold some of that back. But again, it's a huge piece of the puzzle that then you're withholding, that doesn't allow the doctor to do their job, and then they're handcuffed and you can't get to the root of what you need. So if you can't do that, then you can't have a positive working relationship with somebody.
Yeah. So if you're depressed, you're anxious, you've got X, Y, or Z conditions, you're on opioids, like, big deal.
Right.
Just tell us.
Yeah.
Like, we can work through it. They are just problems to work through.
It's just information. Yeah.
The one thing that we don't like, that I think you don't want, and we've got different ways of writing this to us in, doctor speak, is essentially patient doesn't follow advice. Okay.
Right.
So
patient will not do as asked. Yeah.
Doesn't do as us. Like, that's the one you don't want on your thing. Now, the first thing there is that, let's say that we've gone through a plan. Let's go do this. We get back for a review and you haven't done it. That's actually okay.
Yeah, that's different.
But what you need to do is you just need to explain why. Because once again, the doctor's a problem solver. Like, the problem has just shifted to you haven't been able to, like, execute the plan.
Yeah.
Why? What problems do I need to solve to be able to get you to execute the plan?
This is exactly the same within my coaching too. It's like, all right, if you couldn't execute ABC lifestyle prescription, there's no judgment on my part. There's no frustration or anger on my part. It's just, oh, okay, why? Right? Because any problem is just a puzzle to solve. So Dan too is not looking at that with critical judgment. It helps him come up with solutions to help you do that and lower the barrier to entry to those things, whether it's getting a scan or doing things in your own lifestyle, whatever it may be, is overwhelm causing it on and on.
And so this is where, from a doctor perspective, so anyone who's a clinician that might be listening to this is something that's really just become obvious to me in the last 12 months. And one of the main things is literacy. So the reason why people don't execute on our plans is because a lot of the time they don't understand us. And so it's one thing to not execute on our plan. But if you just don't understand, that's okay. Like, we can work through that issue.
Figure that out. Yeah.
And so doctors understand. So for anybody who's listening, in Australia, 44% of the population has year 10 level English and below. Okay. So that means they have difficulty with reading forms, filling stuff in, and they have difficulty with reading bus timetables. That's sort of around where you get difficulty with breakdown.
Yeah. In America, it's even worse.
In the US, I couldn't believe this number, but anyway, 54% of the population have year 6 level English and below. Year 6. So if you've got a 6-year-old in your room, or six. What's how old is year 6? You say 11, 12. 11, 12.
Right. You're
11-year-old.
Yep.
You got 11-year-old level of English. Like, I've got it. I got a 10-year-old. So I am not explaining to her.
However, she's really smart.
She's really smart. But nonetheless, I'm still not gonna explain it to her in the way I'm gonna explain it to her. So understanding that, number one, it might be just that the patient has a lower level of literacy, and likely there's a 50% chance that they do. So just go with that first.
There's a disconnect, right? You've
got to simplify it. The way you pick up on some of those things within a consult is some little cues. So what medications you're on? I don't know my medications. Oh, okay. Now, a lot of the time that's because they can't read what's on the box, so they can't tell you what it is. Or they'll use a cue, or what medications are you on? I don't have my glasses. Or my wife handles that stuff. Or my partner handles that stuff, et cetera, et cetera, et cetera. So when I start to hear those cues within a consult, I start thinking, I've probably got a literacy level, like a lower literacy level here. I had a patient in the other day. They came in pretty much as a husband and wife team. his literacy level was clearly lower. She clearly was like covering all bases, was completely prepped, had everything together because she knew what she was managing.
Yeah.
I previously wouldn't have recognized that, but I, because of some of the interaction, I was going, okay, she's managing his literacy, which is like fantastic.
Good teamwork.
But we just need to be able to recognize some of those cues. So then you change, or I then change the way I interact with patients. I drop I drop the complexity in my language. I drop the complexity of a plan. I break it down into smaller steps. So I might just do 1 or 2 things first rather than 3 or 4, et cetera,
Make it more accessible.
The other important things in this, recognizing what patients don't execute.
Yeah, barriers.
Is because they may be depressed or anxious.
Anxiety. Yeah, that's the overwhelm stress piece.
I was reading a great paper the other day. Actually, I sent it to Josh. What is the interaction between psychology and complex medical disorders? And it comes down to adherence.
Yeah.
If the patient is so anxious that they can't make a decision, then you've got to treat the anxiety, get them through the anxiety so you can then execute on your plan. Similarly, if they're really, really depressed and they just can't get themselves out of bed to execute, okay, we just got to treat let's get on top of the depression and then...
Well, and that's so classic when you look at movement, for example, with complex pain patients, right? What is the barrier to movement? Sometimes it's, I can't even get out of bed. I can't even get myself to care, right? That's this indifference, those types of pieces where it's keeping you from doing the behavior that would help your pain. And so if you just keep banging your head against the wall, trying to come up with a bunch of different movement strategies, well, that's not actually the problem. That's blocking them from doing the thing. Yeah. So it's not just that it's amplifying pain, it's that it's keeping you from helping yourself. Similarly to opioids or other medications with high side effects where the downsides are now outweighing.
Like I had a patient the other day that has terrible neuropathic throat pain, and we, amongst doing a couple of other things, we aimed to start her on a little bit of gabapentin. And she went and read the side effect list from gabapentin, which is, as long as your arm, and then didn't take it. And so when I talked to her again, I said, hey, how'd you go with the gabapentin? I didn't take it. I was like, okay. Let's run through why. Why didn't you take it? I looked at all the side effects and blah, blah, blah. I don't want to deal with that. Okay. The good thing about this is that, let's do a bit of a balance between the two. There is 100% chance that you have ongoing terrible throat pain. So so we don't do anything ongoing pain. If we do try some gabapentin, what are our risks? Okay, so there's a 0.1 risk of X. There's a 0.3 risk of Y. Yeah. There's a 1% risk of this. Great. Okay, so we're at 100% risk of pain. There's a 1% risk of sedation. Great. That starts to put it into context. And then you say, and the other thing that's really important is that if you take it and you get a bunch of side effects,
you can stop
it. Right. And that's okay.
Fixable problem. Whereas if you do nothing, you're stuck. Right.
Now, the flip side might be that you might be the 1 in 8 people that gabapentin turns off their pain and they get no side effects. Like when, I find that it's a great medication. Pregabalin, Lyrica, same. 1 in 8 people, they take it, no side effects, no magical weight gain, pain goes away, like magic drug. And so we worked through those fears, and she was like, okay, I gave her some other strategies in how she could start it, and I'll talk to her in a couple of weeks and we say, how you go. And so that it's those things that you need to be able to look for. The other things then are the fears that you don't know about.
Patient concerns because of life experience stuff.
I say to a patient, we need to do this intervention. And in the background, mum died because of that intervention. And they've now got the same problem and they refuse. And you're like, okay. And
why?
They never, nobody ever tells you why at the start. They just say no.
Yeah.
And that's sort of like, okay, where am I going to go with this? But I think that, from a patient perspective, if you go, you know what, I get that, but mum died when someone did that procedure, the doctor's going to go, oh, okay.
I understand. Right.
I understand.
That's where,
Let's look at let's look at
Yeah.
some other options.
Yeah.
So
That's not unreasonable.
that's our
Yeah.
plan A option. Let's
Right.
look at B, C, and D as other options, and
Yeah.
you know,
And that's where like the doctor can respect those things and
yeah,
come up with a different solution. But if you as a patient too scared to even say that or to tell them because you're, scared of being judged, well, then you can't find a better alternative. So again, it's all this ties into don't leave stuff out, even
don't
when
leave
it's
stuff out.
not medical history related. Yeah. But why do you feel certain things?
Yeah.
Yeah.
And from the doctor side, don't blame the patient if they don't execute on something.
Right.
Like if they don't adhere
do
to the
something you
plan,
think they should.
they've turned back up to talk to you again. They haven't done the plan because they think you're an idiot.
Or because they don't care.
Or because they don't care, or because they don't want to get better.
Right.
They've not done the plan for something outside of that. Now, if they do think you're an idiot, they're not coming back. So don't worry about it. So you don't have to worry. If they've turned back up, haven't adhered, just look for what the adherence issues are.
Yeah, and it's no different than patients preferring, not going down certain routes with medications versus procedures. You can respect those wishes and come up with alternatives. That's
our job is to, everyone forgets the evidence-based medicine piece.
I was just going to say that,
which is including the
patient's
preference
wishes.
of the patient's wishes. That's
right.
it. So
it's not just taking the data and shoving it down their throat.
Best scientific evidence, experience of the doctor, wishes of the patient. So if the wish of the patient is, I don't want to jab, okay.
Fair. Right.
Fair.
That is part of evidence-based medicine. Yes.
I'll go to the next best scientific option within my experience. Move on. All right. The last piece in rule number 8 is it's okay for the doctor to say they don't know. So here's the thing. Doctors are really bad at saying, I don't know. And this is what leads to a whole stack of conflict.
This is where harm gets created.
This is where harm comes.
Patients, feel.
So as a doctor, I don't know. I don't know when I realized that stuff wasn't in patients' heads a long time ago, but I never really had the words to get there. There was a colleague, mentor, friend, Bruce Mitchell, that he looked after very complex patients. And I'd hear Bruce say, I don't know. He'd actually go, I don't know, mate. Everybody would say. And I started to recognize that his ability to be comfortable with saying, I don't know, allowed him to then say the next thing, which is, but this is how we'll work it out.
Right.
And by being able to be comfortable with, you know what, I don't know what's causing this. But this is how we will work it out. We're going to do X, Y, and
Z. I'm going to do my best to still help you, right? Or find the answer. Yeah.
Or it's, I don't know what's going on, but this is the person I'm going to send you to help you out with it. So that's that's number 2.
Yeah. And this is where you have and want appropriate referral triggers, right? I mean, no doctor can know everything about every piece of your history.
Yeah.
So
and I think the last piece, the last thing, so the 3, I don't know, but this is how we investigate it. This is who I'll send to. The last piece is if you don't have those 2 things there, let's say that you're seeing somebody, you're like, you are not in my right. Yeah. You're not even in my sphere of what I understand is going on.
Super comfortable doing. Yeah.
It's then you just go, I don't know. I'm not the right doctor for you.
Right.
You need to talk to your PCP, your general practitioner, about who to see. But I'm not the right doctor.
Yeah.
None of those are, I don't know, you must be crazy. Right. I don't know, you're lying. I don't know,
that's not possible.
That's not possible.
Right.
Those answers are inappropriate. Those answers generate conflict. Those answers generate people in conferences telling
those are the
people
types
to
of
refer
things,
doctors.
Right? Those are the types of things where, that's not appropriate care. But what is super appropriate is for a doctor to admit that. And even though that can be disheartening and frustrating and disappointing to hear as a patient, one has to appreciate that because it helps you get the help you need for that piece rather than trying to squish a square peg in a round hole, right? Or working with someone who that's not their zone of genius or area of expertise. So that can be, really disappointing, especially when you wait 3 to 6 months for an appointment. And then the guy's like, sorry, I can't help you. But that is actually a commendable quality.
And you know what? And like I have some patients when I go, hey, I don't know what's going on, or I don't know what the cause of this is, but this is what I'm going to do. I get some patients that are frustrated because what they're wanting is they want to walk through the door, tell me their story, and me to go magically after 14 years and 20 other people they've seen go,
right, figure it out.
This is what the problem is.
Right.
And I can't. They get frustrated. I said, look, I can tell you that it's something.
I could make something up.
I use that. I said, look, I can make something up, or I can tell you the truth, which is I don't know, but I'm going to do this, this, and this to work it out.
Right.
And everybody goes, yeah, okay, don't make stuff up.
Fair.
Let's just go with, this is how we'll work it out.
Right. Yeah.
And that's important. So
yeah, you have to have some humility.
The thing that so after my little lose my
meltdown
shit after the conference, I think the thing that I thought is, you know what would I have replaced that segment of if
that you could have presented on something.
If I could have presented on something in that conference that was
useful,
instead of refer the doctor to the medical board,
right?
What would I have done? And I would have done this podcast as effectively the upshot and said, look, this is what the doctor's trying to do
to approach this. Yeah.
And if you're one of the clinicians in the room, these are the words you can use that, make people feel heard, that make people understand that avoid harm, that understand what you're trying to do, rather than complain that we can't see doctors because they don't want to see us. And
well, you broaden the gap
going to the medical board, which is just stupid.
So, an ongoing theme of this podcast is helping patients better understand where a doctor's coming from and doctors better understand where a patient's coming from. And when you can bring those two groups closer together rather than pushing them further apart and increasing resentment and anger, you get better solutions and everybody's happier instead of perpetuating the problem and just making it worse.
Yeah.
So, that's our 8-point structure.
Let's all be nice to each other. And we'll work it out.
Yeah, we all get along.
All right. Well, let's wrap it up. Very good.
All right.
Thanks, Jazz. I feel much better now.
Okay. I know. This was very therapeutic for Dan. One of our meetings after that, Dan texted me, he's like, sorry about how it was. I was like, you're okay. Even you can't be your best all the time. And then, this is what was at the root of it.
Anyway. All right.
It's understandable. All right. Thanks for listening. We will see you next time. Take care.
Okay. Bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.